Hello, I'm Dr. Harry Jacob, the Chief Medical Editor of Hem-Onc Today, and very pleased to have Dr. Wendell Rosse with us, who is our section editor for red blood cells in Hem-Onc Today. Wendell, as probably most of you know, is the Professor of Medicine Emeritus at Duke University, where he was previously also head of hematology and oncology, and was previously also president of the American Society of Hematology. Wendell, it strikes me that there are very few rational therapies that have come down the pike in any field in medicine, certainly in hematology and oncology. The probably first exciting such rational therapy was the finding that a tyrosine kinase inhibitor, which we now call Gleevec, was remarkably and is remarkably effective in chronic myelogenous leukemia and also now in some gastric stromal tumors. You've had a lifelong interest in paroxysmal nocturnal hemoglobinuria, and it strikes me that this is really the second time that we have seen in the last 5 to 10 years a rational therapy based on biochemical knowledge of what a disorder was about, and a therapy that proposed, and as I think you'll probably tell us, has had a remarkable impact on this rather deadly disease. Tell us about paroxysmal nocturnal hemoglobinuria and how we're now able to treat it.
Well, PNH is basically two aspects to it. One is a cellular defect which makes the blood cells unusually susceptible to the action of complement. In the case of the red cells, to the hemolytic action of complement. In the case of the platelets, to activation by complement. The other aspect is a relative bone marrow suppression, which is usually not that major a problem. The main problem that patients with PNH have had is they have constant hemolytic anemia, which is intravascular, and this is caused by the activation of complement, which directly hemolyzes the cells as they circulate. This activation is completed through the terminal complex and is one of the few cases in hematology in which this kind of hemolysis occurs. As a result of that action, the patients always have hemolytic anemia, sometimes are quite anemic, and they also have the effects of hemoglobinuria, which include deprivation of nitric oxide, since free hemoglobin is a sump for nitric oxide. Those effects sometimes are quite disabling, including smooth muscle contractions leading to esophageal spasm and erectile dysfunction, and a feeling of tiredness or asthenia. In addition, the hemoglobin is filtered through the kidneys, and the kidneys are very often affected. About 10% of patients die of renal failure, and 30% have serious renal disease, and 60% have some effect on the kidneys. And finally, the most important part of as far as pathogenesis is concerned, is the occurrence of thromboses. These are often devastating thromboses, often intra-abdominal, but also in many other places, nearly always venous, and thrombosis remains, up until the present time at least, the leading cause of death in PNH. And you're right, PNH is not a benign disease. It's chronic, but the mean lifespan for most series in the Western world is 50% to mortality by 15 years. And since it affects young people, this means a markedly shortened lifespan for many of the patients that have the disorder.
So what would be a rational therapy for PNH, and do we have one now?
Well, we do have one that is derived from our knowledge of the complement system, which is extraordinarily complicated, as everybody knows. But it does have the characteristic that all the complications come down to the formation of the so-called terminal attack complex, starting with the fifth component, C5, running through C9, which inserts into the membrane and lyses the cells. So that it has long been felt that one rational approach would be to inhibit the formation of those complexes in some way. And recently there has developed an antibody which binds to C5 and prevents its activation, prevents its cleavage and activation, and thus prevents the formation of the terminal complex of complement. And this drug called Eculizumab or Soliris is extraordinarily effective in controlling many of the clinical aspects of PNH.
You mentioned one of the perplexing ones. Most hematologists, of course, are aware of the hemolysis, which is how the disease got its name. But you mentioned that free hemoglobin, in this case, which is an unusual thing in a hemolytic anemia, it sops up nitric oxide, may be involved in smooth muscle contractions. These patients do have a lot of trouble with abdominal pain, esophageal spasm, and as you mentioned, erectile dysfunction. Have those been improved as far as we now know with the use of this inhibitor?
Yeah, the studies that have been done, which have been very carefully studied, about 190 patients, the relief of the symptoms has been dramatic. Esophageal spasm has almost entirely disappeared, if not disappeared. Erectile dysfunction has virtually disappeared. The abdominal pain, we know less about. That was not as carefully followed as it could have been. But one of the major effects has been a loss of the asthenia, the fatigue, the tiredness that patients feel. Some patients say they have not felt this well since they got PNH, and I think that in the patient reports they often refer to that as one of the major factors that have improved their life immensely.